Welcome to Delaware Healthcare Reality, a podcast presentation of the Medical Society of Delaware with Dr. Nicholas Biasotto. Dr. Biasotto is board certified in family medicine, and he has extensive experience and training in treating patients with addiction and substance abuse. Now, let's join Dr. Nick Biasotto for Delaware Healthcare Reality.
This is Nick Biasotto, host of the Medical Society of Delaware's podcast, Delaware Healthcare Reality. And our guest today is Dr. Bhavin Dave, our 179th president at the Medical Society, recently inaugurated. Dr. Dave had his medical college education in Baroda, India. He finished his residency at the Medical College of Philadelphia in internal medicine, and he received his fellowship degree in gastroenterology at the Medical College of Pennsylvania. He's board certified in medical specialties of internal medicine and gastroenterology. Presently, he is Bay Health's Medical Center Associate Program Director for the Internal Medicine Residency Program, and he is also the Director of the Gastroenterology Fellowship at Bay Health. He is presently also assistant professor in the Department of Medicine at Drexel University. He is also Philadelphia College of Osteopathic Medicine's clinical assistant professor, and he is Arcadia University preceptor in Glenside, PA. He's also editor of our Delaware Medical Journal, and he has received the Teacher of the Year Award from Drexel University. He has many publications, which I will not list now, but I'm sure they're very interesting and very rewarding to have performed. Now, welcome, Dr. Dave. How are you?
Thank you. How are you doing, Dr. Biasotto? It's been a while since I've had a chance to sit down with you. I'm very much looking forward to the questions that you have.
Okay.
Please be kind to me and make it simple.
I'll be as kind as I can. Well, what is your platform as president of the Medical Society? What are your interests, and what would you like to see done for the physicians and patients of Delaware?
Obviously, everybody has the same goal, and that is better health care in a cost-effective way. But lately, we have seen a significant progress and advances in technology. One of them, of course, the forefront, which is on everybody's tongue, is artificial intelligence. And we can talk a little bit more about AI. So obviously, I am very interested in AI, and we can talk about the future in medicine with AI a little bit later. The other thing which interests me is, obviously, since I am very involved with residents, medical students, and PA students, and also GI fellows, my biggest interest is to nurture and cultivate an interest for the young residents, students, and everybody, cultivate an interest for them in having a commitment to the legislative side of medicine, the other aspect also being getting more involved in Medical Society of Delaware and a variety of different organizations. I do believe that right now they are not encouraged to be active in those organizations and society. I think these societies and legislation is extremely important to the business aspect of medicine and also the future of medicine in many different cases. Sometimes legislation is in such a way can put primary care physicians in jeopardy. Their existence right now, many people foresee, is in jeopardy. So there is a significant aspect of medicine that goes hand in hand with legislation. So that was the second. The last objective of my focus is about how environment is affected by medicine. And we all face a dire crisis of global warming. We have broken several records just in the year 2024 with global warming. And this is going to continue. And it's going to create a whole lot of different medical kinds of diseases to deal with. And the other aspect is there something that we could be doing differently to halt, maybe stop the global warming issues? I know this was long, I know this was lengthy, but those are the three primary objectives that I have.
Very good. I see that engagement is very important. We have to have doctors that are residents and coming out into the field and starting a practice be engaged in our societies, because that's your profession, and we foster the benefits of the patients and doctors in Delaware and in the United States, joining the AMA, the AOA, or the State Medical Society. I understand that. And yes, global warming is an issue. There's no doubt about that. But I think that that's going to be a lot of a push to get that straightened out. But I'm interested in what diseases do you think global warming is going to reintroduce that maybe weren't introduced in this area, let's say?
So let's start with the basic and simple stuff. Global warming, increased temperature, and a higher humidity. And you know that the fungal infections thrive on warm, humid environment. And if you look at the recent trend, you'll find that the incidence of fungal infection is going higher and higher. And nowadays in the ICU, we are even seeing deadly candida infection like Candida auris and a few other things. That is definitely going to go up. So that's one aspect. The second aspect is that with the global warming, of course, you're going to see dehydration and illnesses that occur along with dehydration, including higher incidence of renal failure and things that go along with it. The third thing is we will probably see more and more of bacterial mutations. The mutations perhaps might be at a more accelerated rate. And the other issue that can possibly happen is that new species of bacteria will come up because of there'll be different kinds of bacteria which find it lovely to be in a higher temperature and a more humid environment. So I think this is just like it's going to be multifactorial. Besides infections, I think the incidence of other diseases like renal failure and other things will probably occur too.
Interesting. Actually, I never thought of it at that point. Now, some of the initiatives here in Delaware that we're working on are the primary care reform, an initiative to increase primary care's presence and existence in the state itself. Previous studies have shown that every dollar invested in primary care can save up to $9 to $10 in the overall cost of care per individual in the country. And yet we're seeing less and less people going into primary care medicine. Now, I'm a primary care physician. I've been a primary care physician for 45 years. I have a solo practice, and I've practiced solo almost that entire 45 years. And I found it more and more difficult to keep the roof on and keep the lights on and pay the patient and pay the people that I have working for me, nurses and secretaries, etc. And it became almost impossible to maintain a practice. And I was going to retire 9 years earlier. However, I was introduced to concierge medicine, at which time I then switched over because I love what I do. I like what I do. I'm still good at it. And I want to stay that way. And I just didn't want to retire. And this offered me a way to give at least a smaller population of people the best care I could give them. So it seems that we are trying to ask state and federal governments to help primary care survive. It's almost impossible to find a primary care doctor, at least many people are telling me that, and it's almost impossible to get to see a primary care in a timely manner. What do you feel about the primary care initiative that we've been pushing on for years through the state legislature?
Yeah, that's a very, very good question, and I think you hit a little bit on the financial aspect, but there is a little bit more to that, and it is the emotional toll that primary care physicians deal with. As we know that medicine has expanded so much in knowledge, so many more new drugs. It's almost like the number of new drugs coming out doubles every decade or so.
Easily.
And don't quote me on the exact number, but it's substantial. And a primary care has to know every one of them, at least a little bit, if not as much as the specialist. And then, unfortunately, just besides the cost issue and the knowledge issue, then primary cares are dealt with a lot of frustration coming from insurance companies, denials, prior authorizations, coding issues, and it's just a whole host of things that are just beyond imagination and comprehension. I'm sure that when you were in medicine, and I know that when I was in medicine and I was studying, I thought, you know what, I just need to know as much as I can, and I'm going to be a good doctor. I'm going to be caring. I'm going to do the best, and, and I will be very happy taking care of patients. And then as we continued to practice, reality dawned upon us that the medical knowledge is no longer the priority, but the medical economics, the frustration and harassment that physicians get, especially primary care. They're getting attacked from all aspects. Finances, insurance companies, different kinds of legislation, even just to get recertified. State introduces more and more mandatory courses that we have to take. It just takes an enormous amount of toll. So it's tough, and this is where it requires very coordinated effort from the societies, from private care, private and hospital-based physicians, and even residents. They really need to raise their voice, let the public know, let legislators know that we are dealing with a situation which could see the demise of primary cares. Residents don't want to do primary care; they want to go into specialty.
Yeah, I'm told by the students and residents that I treat that they would not go into what I'm doing because they come out with a $250,000 debt from medical school, and by the time they pay it off at the rate of payment that the primary care doctor receives, they'd be in their 60s. So they want to go into a specialty which pays more, and obviously that's why some have done it. But that leads to the cracking of our foundation in medicine, because I believe primary care is our foundation. So that's important, and I hope you push down in Dover for some of these reforms that primary care docs have been looking for the past few years.
I'm very much committed to it.
Thank you on that. And authorizations, prior authorizations. I've done an editorial, I think it was our third podcast, on the uselessness and frustration and the absolute lack of transparency on the effectiveness of prior authorizations. I've asked the insurance industry for years to give us a reason why, show us the statistics that they are saving money or saving lives. And this has been since 2008 during my presidency. I started it. I have not heard that answer since. So I'm not sure this program does anything but give insurance companies control, and that is it. What's your feeling on prior authorizations?
I agree with you and a whole lot more.
Mm-hmm.
It's a sore subject for me. It's an anguish that I face almost on a regular basis in the office, and I'm one of almost every part of medicine faces this kind of anguish and frustration. And we deal with it from 2 or 3 different ways. It's mostly because we were always trained to care for patients. And our anger and frustration doesn't only come towards the insurance company, but it gives us a sense of helplessness and frustration that I can't take care of my patient.
Right.
I just can't do it. I can't, start rowing a boat with 2 hands tied behind my back, and that's exactly what we're doing. We're asked to row a boat with hands tied behind our back and wait for the insurance company to go ahead and have us send a little bit of breeze, and maybe that boat will go in the right direction. Mm-hmm. It's sad. It's absolutely frustrating. But do you know what? Can I tell you something?
Shoot.
When you're not able to deal with it, it's your fault. We call it burnout.
Exactly.
We are not allowed to say that we are suffering almost like a post-traumatic stress disorder from all of this abuse that we're getting. Oh, no, it's your fault, my dear doctor. You are facing burnout. Right. You need to take time off.
Right. But then the patients can't find you or see you because you're taking the time off. And if things go like this, doctor burnout is a big issue, as you know. That's just part of it. The EMRs are another part of it. Plus, all the bureaucratic red tape we have to do and all the paperwork we have to do beyond patient care that occupies more of our time than actual patient care. And if things continue like this, by 2033, there's going to be something like 150,000 doctor shortage in this country, which we can't use that right now. We can't have that right now because it's difficult to find a doctor to begin with now. What about then? So things have to change, and I hope our federal and state governments come to that realization and give the doctors their due and take away some of the burdens that we have to face every day. Okay, are you familiar with House Bill 350?
That was a sore subject from last year, I believe. Am I correct?
Uh-huh.
It was introduced by Senator Townsend, I believe.
Uh-huh.
Okay, yeah, I'm somewhat familiar with that.
Okay. I'm not trying to put anybody on the spot. I just don't know that the hospital system is doing it properly. According to all the data that I read, the cost of care in the United States is very high, super high. Outcomes are poor, and that has a multifaceted reason. Could be patients not really doing the right things, not trying to live right. But the cost of care is so high that it's soon going to be unsustainable, and our outcomes are poor. Now, the hospital systems are the generators of a high cost of care in this country. A lot of people can't find that primary care doctor, so they go to the hospital. The emergency rooms are overwhelmed. The cost of care in the hospital is pretty high for many reasons, which I hope to go into it later in an editorial I'm going to do regarding this. But what do you feel about budgeting a hospital, keeping to a budget, spending limits, etc.?
Okay, so that's an excellent question that you brought up. But let me counter it with a question back to you. What percentage of the hospitals do you think are red, and how many of them are black? Above? Are
in the red and in the black?
Yeah.
I can't answer that. I don't know.
No. So almost all of the hospitals in the country are in the red. They are in the red. So there is something wrong. There is something wrong with the whole picture, wherein even though their charges might seem outrageous and might be outrageous, yet the system has been set up in a way, it's almost as if it's designed for failure. But let's look at it this way. Do you know that, from what I've heard, is that most of the dollars spent on healthcare, about 60%, 70% goes towards administrative costs.
That is correct. I was going to bring that up.
Yeah. So basically, as a patient, if I was giving money to my doctor or to the health insurance premium, right, and almost all of your money is going towards an administrative cost, okay? And I have no idea how much of the administrative cost goes towards the CEO and the shareholders, right? That doesn't seem right. That just doesn't seem right. So I'm going to change the picture over as that maybe that although the system seems to be we are trying to control the budget and finances of a hospital that is just floating above water, instead of really addressing the major issue is the costs which have gone out of control. If you think about it, just look at the cost of pharmaceutical industry, and this becomes somewhat tricky. I routinely prescribe, say, for example, medications for inflammatory bowel disease. They are the biologics. They can easily cost $15,000 to $20,000 a year. And we may think that, when the drug becomes generic, it's going to lower the cost. But the system has been set up that even the people who manufacture the generic drugs are making a whole lot of money. Technology itself, when it progresses, they charge exorbitant prices for the new technology.
Who's they? You mean the company that sells you the equipment? Yes,
exactly right. So whenever a new equipment comes out, it costs a whole lot of money. The stents themselves are for coronary stents, they are very expensive, and they keep on changing newer stents. And so anytime there is progress comes with a price tag. And the third issue is the ancillary services which the hospital provides. They're all and not just hospital, but when you refer them outside, home health agencies, nursing agencies, the equipment that patients need to go home on, they have all become expensive. So, like I said, control of a budget is far more important than actually just increasing revenue by charging more. And that is the one aspect, like if you were in your home household, right? Let's say, for example, and if you wanted to do something extra, you put a cap on your budget. You don't say, I'm going to work a fourth job. It's just not possible. Unfortunately, almost all of almost everybody, like in the hospital and everything else, they're not able to control the cost. You cannot increase your revenue. I don't think anybody can really increase their revenue or reimbursement for any given CPT or ICD code. It's almost fixed and it's almost determined by Medicare. So your income will never go up substantially unless you're providing a new kind of service. But your expenditure, controlling the expenditure is the best way to get the hospital systems and healthcare is much better.
I have a little bugaboo about the cost of care from hospitalizations. I really do. I think it's outlandish in the sense that if I want to get an MRI of the brain at the hospital, it's $2,000, but outside the hospital, it's $850. When the magnet's the same, and sometimes the radiologist is the same. He's just moonlighting in another place. So something's wrong with that. Is there any truth to the possible standardization of testing across the board? Saying that an MRI here costs the same as MRI there, etc. Because I have seen patients get their MRIs at the hospital setting, in a hospital setting, pay double what they see on the outside, or any other test for that matter. So what does the hospital need to be paid so high for that test for? Do you have any answer to that, or is it unanswerable?
So I don't think it's unanswerable. All of these reimbursements have been set up by CMS. Most of these reimbursements. It's not that the insurance companies are really eager to pay the hospital system more.
But CMS is paying hospitals more than what they're paying the outside. That's not fair, is it?
So I'm coming to that point.
Okay.
So when CMS set it up, it's not that they were really eager to pay everybody a whole lot of money. What was happening is that the hospital does take care of a lot of patients who come in who are uninsured. So those uninsured patients do eat up a whole lot of budget for the hospitals.
Well, a budget would tell us that, okay, so they're paying that amount for an MRI. They're uninsured. Is that amount justified for the amount of uninsured people that they care for when you add it all up? I don't know. That's what a budget would tell me. Not to push the issue, but I know as the Medical Society we're neutral on House Bill 350. There's some that say it's a good thing, some say it's a bad thing, some say they're in the middle. So
my feeling is that I think the legislation is still not looking at the full picture. The full picture is, the cost of the GLP drug. It's going to destroy the country. It's going to destroy the country. I think in West Virginia, they started paying GLP for the school teachers, and then when they saw the cost and what their budget was going to be, they quickly rescinded it. So then some of the newer drugs which may have a long-term benefit but not a short-term, it might be really, really expensive.
Well, let's talk about the GLPs. Obesity is one of the biggest diseases in our country.
Yeah.
Such a large percentage of people are overweight or obese. And obesity leads to many diseases which we have to treat as time goes on, which is a costly thing. So when you look at the long haul, is it worth bringing those patients who are morbidly obese or obese down to normal weights and healthier conditions? The patients I've had put on myself, have improved significantly in the way they feel, in their numbers, their A1Cs, their blood pressure, their cholesterol, etc. So, I know what you're saying, and that's just one little thing. But there are a lot of others that we could discuss. But I understand your point, and I see the points of those who say maybe we should keep a closer eye on the costs that the hospitals are doing. So, but at House Bill, we're
But the hospital is faced with those mandatory increase in costs because of cost of living going up. The pharma industry keeps on increasing their pricing. All of the vendors that they get things from, they keep on increasing their pricing. And think about it. When was the last time you saw a CPT and ICD code give more revenue to anyone? Never. So here we're looking at a hospital system which is facing a fixed income, which is probably not going to go unless they have more and more people, coming into the hospital. But they have ever-increasing expenditure from all of these other things.
Okay.
So so the focus should be, and it should be somewhat different. And this is just my opinion. The focus should be is we need a global overhaul of the healthcare system. And, so one of the biggest expenditure is the last 3 months of, last 2 or 3 weeks of life. It's $500,000, $300,000. And, I have often wondered, do you think that $300,000 could have, when you have a limited budget, is there any other use that we can have? And I'm not saying that we terminate healthcare, but we need to have better technology, maybe a better way to predict and deal with outcomes.
All right, your personal opinion, Bhavin, do you think we should go into a one-party payer system of sorts? Now, I'm not talking about the ins and outs of that one-party payer system, but one-party payer system where you know everything off the top. You know what you're going to get. You have to deal with one person. You have to deal with 20 insurance companies you don't have to deal with, etc. What is your thought on a one-party payer system?
So that's not a straightforward question, or it's not a straightforward answer either. And this is just my opinion.
That's what I'm asking.
Okay. Is, let's say, the private healthcare insurances, right? United, Blue Cross Blue, Highmark, whatever. Exactly. We have so many different kinds of healthcare. So most of the people who get those insurances are people who are working. Usually some of the payment comes from the employee and some of it comes from the employer. They are usually between the ages of 20 to 60. Okay. Now, if I asked you, I'm going to have you give insurance to the healthiest population of the country, what do you think about that? These are people who will get insurance but will not be using it for most of it. Think about it. It's a sure bet for them. So now you have a person who might have, say, Highmark or United going on for 40 years, and what percentage of that money is really going to get used? Just think about it. You're in primary care. You probably see one person in the family, but the rest of them are all healthy. They probably don't need anything. So they are making a whole lot of profit. And now you take Medicare. They are insuring the sickest population. So here we have set up a system wherein the healthiest people get private insurances for profit organization, and CMS takes the losing end of the stick where they're insuring Medicare. And taking care of Medicare. They're taking care of the sickest population. Just go figure.
Well, let's make it Medicare for all.
So the question is, I don't know if I really trust the government to use the money properly.
We've been talking about that before. Now, I have a concept, and I don't know if I've heard this or read this anywhere, but I don't think so. If you had the government hold the coffers, have the money, okay, and then distribute across the country in every section of our 4 time zones, one of the bigger insurance companies, say Highmark on the East Coast, just to say, Cigna on the Central, the Mountain, Aetna, and the West Coast of U.S. Healthcare.
Yeah.
And you allot them a certain amount of money to take care of that section per capita, depending upon per capita, and, I mean, historically, their conditions. And, the East Coast may be not as healthy as the middle section of the country. Yeah. And you say, this is what you got, this is what you use. If you save the system, you keep the profits. So we got the capitalistic system still working, and yet we have still a one-party payer because it's all the government paying the money. Because in the long haul, they're paying the money anyway.
Right.
So what do you think of that?
Well, I think a lot of smaller details would have to be worked out.
I'm sure they would.
But that's where I have a feeling that AI can come into a huge play and help us out. So,
well, talk to me about that, because I'm not as up in AI as you are.
No, absolutely. So, I think yesterday they just announced $500 billion to be given for AI.
Yes.
And so what that new announcement, that's a huge number. And I don't know if people really have an idea how much, $500 billion is. And just to give you an example, 1 million seconds is about 12, 13 days. And then you jump from a million to a billion, it becomes 34 years. 34 years. When we jump from 1 million to a billion, 34. And from a billion, if you jump to a trillion, that's 34,000 years. So that's a huge number. So when the government is saying that we're going to spend $500 billion extra for the budget to come up with a robust program for AI, it is going to give us, it has the capacity of doing some cost saving. Okay, so that's where, so the part of the issue is with AI. Let me just start off with the story of AI. So we have talked about AI since the 1940s, 1950s, and it's been going on for a while. But I think the real change occurred with DeepMind in 2015. Mm-hmm. So DeepMind, which is a part of the computer system from Google, it created something what is known as AlphaGo. And AlphaGo was a program. So until then, we had programs that used to play chess. But this is where instead of actually playing chess, it actually understood the moves. And it was said, these are the moves, figure out what needs to be done. And that is AI, because now it is not really saying, I have the preset database, I'm going to follow it. It is going to decide what it wants to do. Mm. And then, like the first AlphaGo, second AlphaGo actually started beating, one of the hardest games is not chess, it's Go. It's an Asian game called Go, and extremely challenging. So it started beating any player when they're playing Go. And then in 2017, they came out with the second version. And the second version was absolutely incredible. That machine was so powerful, it just went and said, I'm going to give you 2 or 3 extra moves. I'll show you how you play the game. I'll just tell you the moves, I'll tell you the results. Your goal is simple, win. That's it. Did not feed any other data, because until previously they had data which would show different kinds of games which were uploaded, and it would just follow the pattern and knew that this was a winning pattern. 3 days later, Go, just 3 days, Go became the champion. Nobody could ever beat it. So now we're talking about something, a machine that can teach itself. Learn the game. And that happened in 2017. And that is, to me, is very, very exciting.
It is exciting. But so, I have memories of 2001 and the computer HAL that took over and ran the ship.
Right.
So, there has to be some controls.
Yes.
Okay. So you seem to be really excited about that.
I am, and so let me tell you. So they use the same technology, and guess what? They use that technology to figure out the whole DNA structure of the COVID virus. Mm-hmm. They used it, and then they started coming out with, they came out with something different, and they came out with an artificial intelligence software that would create protein molecules that can help you fight diseases. It would predict the protein molecule structure, and it turned out to be very accurate. So that is something absolutely so incredible that we are, and that started in 2020. Okay. Now, the other thing the AI can do is, let's say, for example, if all of the hospital systems are connected anonymously, right? And you have like a picture wherein in the ER, you have data saying that all of these patients came in with fever and they all had a pink spot on their face. I'm just making it up.
Okay.
Guess what? As a human being, we can't really know what's happening in other places. But the AI has the ability to know exactly, there are 50 different people in this particular area that came out with this exact thing. It is able to predict way before you get an epidemic that there is something that is going to happen. This is going to change everything.
I agree.
You already have AI which can predict the molecules, and they can. So they are still facing some kind of issues, even though there is the newer alpha program like I think it's called.
But can they cause you to manipulate the molecules?
Oh, absolutely.
Well,
absolutely. And people have already started working on manipulation of the bacteria. Mm-hmm. So there are people on the dark side which may be doing something along those lines.
Yeah, you got to have some controls and you got to watch it because it could be a good thing and then it could be a very, very bad one.
So the AI can help us create more vaccinations. It can know what kind of implementation is done. It will tell us ahead of time before the disease epidemic occurs. And I think in population model, it's going to excel itself. Everybody knows that Google looked at data of everybody who came into the hospital, and all they did was put in all of the data on every single patient that went into the hospital, and it asked them, can you predict who's going to die? And with the million different parameters, it found a pattern and said, this person's going to die. And it turned out it was accurate. So this is AI. We as human beings are not able to do that. But when the full power of AI is released, I think that it can help us deliver cost-effective, incredible medical care.
Well, I hope your lips to God's ears and not to somebody else's ears, if you understand.
Thank you. Yes, saying. Absolutely.
We need to have parameters and control.
Right.
Well, Dr. Dave, this has been a very interesting conversation. I would like you. Do you have a book on AI that you would recommend that I could read and it would be a simple read, not something that's going to be complex?
So it depends on what aspect of AI you're looking at. There are different. The history by itself, to me, just reading the fascinating history, and I think it's better to rather than reading a book, you can just look it up. There are some really good web pages about the evolution of AI. Mm-hmm. Recently on Medscape, there was an article that talked about the challenges AI faces in creating new molecules.
Okay.
And, because we know it's like a lock and key mechanism because it can predict a protein that helps treat the disease. But when that protein attaches to the cell changes its configuration and AI can't predict it. But that was in 2020.
Right.
But they are coming out with newer and newer AIs that can even do that. Wow. I think there is an exciting future. It just gets me.
You're getting me excited just thinking about it, so I may have to look into it a little bit deeper. Anything you would like to bring up that we haven't discussed?
Well, so most of this stuff was my opinion. The other aspect that I did not really talk about what can we do to get the residents and other people more interested, and a sort of a mentorship program. Maybe have them follow a legislator or somebody in one of the medical societies and train them along those ways. And sometimes maybe even monetary incentives can actually get them a little bit more motivated into taking more of lessons and legislations or legal aspects of medicine. There's certain courses which might help them and cultivate their interest.
Well, thank you very much, and keep up the good work.
Thank you so much for inviting me. It's been absolutely my pleasure, and it's so nice to sit down and talk with you.
Great.
Thank you.
Okay, this is Dr. Nick Biasotto, the host of the podcast from the Medical Society, Delaware Healthcare Reality, and just completed our discussion with Dr. Dave, our 179th president. Stay tuned for further ones. We will have some very interesting podcasts coming up in the near future. Stay tuned.
This has been Delaware Healthcare Reality, a podcast presentation of the Medical Society of Delaware. For more information about MSD, visit our website, medicalsocietyofdelaware.org. For questions or suggestions regarding our podcast, email us at healthcare.reality@medsocdel.org. Thanks to audionautics.com for our music. The executive producer of Delaware Healthcare Reality is Mark Thompson. Delaware Healthcare Reality is produced by Tom Mitten. For the Medical Society of Delaware, I'm Lori Ann Rhodes. Watch for our next podcast episode. Until then, be well. The Medical Society of Delaware, MSD, is providing this podcast for informational purposes only. It provides neither medical, legal, nor any other professional advice. The views, thoughts, and opinions expressed by the host or any guests are their own and do not reflect the views or policies of MSD. Unless specifically stated, reference to any specific product, service, or entity does not constitute an endorsement or recommendation by MSD. Reliance on the information provided in this podcast is exclusively at the risk of the listener. MSD expressly disclaims any and all liability or responsibility for any direct, indirect, incidental, or other damages arising out of any individual's use of, reference to, or reliance on this podcast or the information presented in this podcast.